Okay. So this is week 2, and in a normal semester, you would think, we're just getting started. But when we've only got 7 weeks, this semester is going to go really quick. So week 2 of only 7 weeks. How'd it go? How'd it go this first week? We're easing into it with the first week, but how was it on D2L? Did everything work okay? Did the videos work? How'd it go? Any problems? All right, I'm going to take that as a resounding A-okay. Okay, so let's look at, I'm gonna share my screen, and we're gonna look at D2L. And so let's look at, first of all, let's talk about the discussion boards. Okay, so here's normally what happens is by Friday night, you all post the bulk of your responses, and then by Sunday night, you should respond to at least 2 of your classmates, read what some of your classmates say and respond to what they say. And remember, always be respectful, even if you don't agree with them. Everybody should be respectful in their posts. So I was able, I just briefly looked at what some of you posted this weekend. And so normally what happens, because everything is due in completion Sunday night, I'm going to spend this week reading over what you posted while you're working on week 2. So, and I'll post some responses to you. My goal is to discuss your responses tonight with you. I'd much rather have a dialogue with you rather than just me posting kind of a general response and pulling out a couple things that you say. So, I'd much rather talk about these things with you. That's my goal. So hopefully that's what we're going to do tonight. So I think in general, I think everybody did a pretty good job. What I saw missing mostly was everybody introduced themselves. Everybody talked about the article being sane and insane places. And everybody looked at the films on demand. What was missing in a lot of them was readings from the book and comments on my class lectures. Now, some people talked about that. But in reality, the most important part are the diagnoses or the history or whatever I'm talking about in the lectures. So yeah, you got to do the extra things. You got to do the articles and the extra videos, but don't miss the lectures. I might tell a funny story or something. I want to hear your response about what I have to say about different diagnoses or the history or whatever it is as well. So you don't have to change anything for last week, but in the future, if you didn't post on the lectures or the readings, please include that with your next discussion boards. That's the only thing I could see missing on some of them. But it looked like everybody, for the most part, was writing at least a page like I had requested. So before we start, I know the DSM training video was a little long. I did send out a thing trying to shorten it a little bit. It was like 3 hours long. I tried to cut it down to around 2 or less. I know it was a lot, but that should have covered everything in the intro, all the way up to differential diagnosis. Okay. Let's look at week 2 before we discuss last week's content. Okay. So and remember, because a normal semester is 15 weeks, each week we're combining 2 weeks. Okay, so it's a lot, but for this coming week, now this very first lecture of mine, it's on 2 things. The first part is on session notes. That part's boring, okay? But the second part of that lecture is on the assessment process. That part's really important. Notes, not so important. Assessment process, really important. So watch the entire video. Now, here's the thing. I'm talking about the assessment process using some old assessments there. On those assessments, you're going to see like the DSM-4TR, which has 5 different axes. We're going to go over what those axes are just in case you run into them. But the DSM-5, it only has 1 axis, 1 diagnosis. You don't need to go into all the different types of axes. It's just 1 diagnosis for everything. But we're going to talk next week on Zoom about the differences. I just wanted to point out those are some old assessment sheets, but nothing else changes but the way you write up that diagnosis. One has multiple axes, the new one just has 1 diagnosis, that's it. But everything else in the diagnosis, the case history, the questions about suicidal ideation, the psychological history, have they seen a psychiatrist, all that kind of stuff is pretty much the same. There are some other types of questions we can get into, which I'll talk about next week. Sometimes I talk about some very specific things now, and we'll talk about next week. Like I might talk about, now I'm a little more forward about talking about gender identity issues. I don't force it, but I bring up the subject and allow people to respond in any way they're comfortable sharing. So I kind of offer them the opportunity. I just want to offer them that opportunity rather than making them bring up that subject. So that's part of my assessment now. Let's see what else. I go into a little more detail now about addiction than on that assessment process. But a lot of times general assessments are very general for a first assessment. A lot of times, I'll spend an entire hour session just doing an assessment. And if I'm working for an agency, they're going to want an answer. They're going to want a diagnosis so that they can get paid by insurance. But now that I'm on my own, I can personally afford to wait a little until I'm a little more sure of a diagnosis. But I'm at kind of a different place in my career. I really want to be sure about a diagnosis. And that's part of a differentiating process. Yes, they have these symptoms, but they also have these symptoms. And moving through this process of figuring out, is it this diagnosis? Is it this diagnosis? They've got all of these symptoms. What's the best fit for a diagnosis? Ruling out diagnoses. Okay, they've got these five symptoms, but they don't have this, or they've got these 5 symptoms and this one symptom. So kind of ruling out these diagnoses and leaning towards another diagnosis. So that's the whole differentiating process, the differential diagnosis process. Figuring out moving away from one diagnosis to another diagnosis. One thing that you're going to hear me talking a lot about this semester that they pay more attention to in other countries is the severity of the symptomology. And so if you look at a lot of our diagnostic symptoms, I could look at my 3-year-old and I could give my 3-year-old multiple diagnoses, but it's a 3-year-old, so it's more about what is their age, what's age appropriate, what's not age appropriate, and what is the severity of the symptomology and the impact on the life. So, a lot of people can have symptoms, but it's really about the severity of the symptom and the impact on their daily life functioning. And so, for instance, in Europe, they not only have checklists for various diagnoses, so diagnostic checklists, but they add a second checklist that we don't really have, and it's called a severity checklist. Ashley, yeah. Did you have your hand
Sorry,
up?
yeah, I do. I wanted to go back. So you said, like if you're like in an agency, they need that like diagnosis like pretty much as soon as they're done, right?
Yeah.
But you said now that you're like in your own private practice, you kind of like give it some time. Like how much time is it? Like
Okay,
after
so
like
yeah,
two?
I'll clarify that because I don't take insurance. That's how I can do that.
Okay. But if you take insurance, it's kind of like, hey, like you need this today.
Yeah,
Okay.
yeah, that's why. Yeah.
All right. Thank you. Sorry, I didn't mean to like go back.
No, it's good. I should have clarified that,
No, it's
Ash.
okay.
Yeah, I should have. Yeah, that's the reason. Every now and then, there was a middle ground when I had a private practice and I was taking insurance, and I could talk them into, 2 weeks, uh, but then I had to talk with them and, basically beg them, and it was more hassle than it was really worth. So yeah, if you're dealing with insurance, then here's what I did then. Then I would go with a lesser, and there is such thing in my mind as a lesser diagnosis. And then I would put an RO, a rule out for a more serious diagnosis. So, I do believe that you can have less severe diagnoses that could lead to more severe diagnoses. So I just wouldn't jump right into a more severe diagnosis. You can always make change a diagnosis and make it more severe once you're more sure of those more severe symptoms. Yeah, so then I go with a less severe, and I'd still put down a more severe possibility, and that's called a rule out, an RO, but I wouldn't make it the primary diagnosis yet. So that's how I would get away with it if I was forced to. So yeah, so here's the thing with diagnoses. Now that we're in kind of an electronic age, even when we were just in a paper and pen age, people didn't realize that diagnoses stick with people for their entire lives. So if a therapist or a psychiatrist or a family doctor, a medical doctor, give a client a diagnosis and it's wrong, that diagnosis will stay with that person with a paper trail for the rest of their lives, even if it's wrong. So, I think it's important to be really careful, to be sure when we give somebody a diagnosis, especially a more severe diagnosis. So I will probably tell this story later on in one of my videos, but since I'm on the roll right now, I had this woman who was 65 years old, and her husband he had worked for the government and he had passed away. And but she believed that she was being followed and they were bugging her phones and men in black cars were following her. And, she was being spied on, and, she was becoming quite paranoid. And so a psychiatrist had her on all kinds of meds, and she was a diagnosed schizophrenic, and she was sent to me for weekly treatment, just for counseling, basically for maintenance. And and by the time she saw me, the meds and all of this, she went from being a fairly normal person to being a bit out of it. And but still convinced that, men in black were following her. And about 3 weeks into my counseling sessions with her, I got a call on the phone, and the person on the other end of the phone said, listen, I know you're not allowed, because of confidentiality, revealing who your clients are or saying anything about them. However, I am a lawyer in Washington, D.C., and I work for the federal government, and it's my obligation to inform you that your client is being observed because her husband died recently, and he passed away under suspicious circumstances, and we are required to observe everyone that he either lived with or worked with for a period of 90 days or until we figure out how he died with certainty. So she was, in fact, being followed, and her phone was being tapped, and men in black suits were spying on her. And she was on all kinds of medications for no reason. And she had a diagnosis of schizophrenia for no reason. And, so sometimes when we get a person who seems perfectly sane and gives us an outrageous story, we might want to give it a second listen. So of course, I immediately consulted with a psychiatrist. We had to wean her off gradually from the medication. And she promptly walked up to the next man in black and told him off. So, the problem is when people receive diagnoses, it can harm them if they want to look for certain types of jobs or join the military or become a pilot. There's all kinds of implications that documented diagnoses will have for people's lives. And it's up to us, So I always err on the side of caution. With that being said, caution takes many different forms. I might err on the side of caution when it comes to giving a less severe diagnosis until I'm sure, but I also err on the side of caution if I feel somebody might be in danger or, in need of medication. And I've been known to stay after work until I could get them see a psychiatrist. And that means missing dinner, staying at work late, being away from my kids, just to make sure a client sees the people they need to see. Not abandoning a client when they're in need. So there are sacrifices to be cautious for the safety of a client as well. Sitting in emergency rooms with clients, and the list goes on. All right. So, and then I gave you all kinds of things like what goes into a good record. What do all those prescription codes mean on a bottle of prescriptions? Here's an example of an assessment. Here's an example of a school IEP, just for your own information. Here's the SAD inventory for suicidal ideation. Here's a video about ADHD and intellectual diagnosis. Here are notes on ADHD. Here's notes on intellectual disabilities. Here's a controversial film on the medicated child. Here's a less controversial film on adult ADHD, regaining focus. So you can compare and contrast these two videos. PowerPoint. Here's a video we'll probably watch tonight together. DSM video. Okay, and then we switch diagnoses. So my lecture on schizophrenia, notes on schizophrenia, films on demand. Here's a documentary on schizophrenia. Here's one on my video, my lecture on personality disorders, dissociative disorders. And then you have a choice, because I know all of these takes a lot of time and you've only got a week. So you have choice. You can watch either the video on personality, either the video on multiple personalities or borderline, or you can watch them all. It doesn't, pick one, two, or all of them. It's up to you. But I know you have, you've only got a certain amount of time in your life. So, all right, let's see. And then discussion board, same as last week, but make sure you talk about each one of the diagnoses and, the assessment process, basically. All right, so questions about next week before we talk about last week? Okay. Let's talk about last week. So give me your take on being sane in insane places. I'm going to exit out so I can see everybody's faces.
I mean, I personally thought, oh, I'm sorry, Victoria, go ahead.
Yeah, Charles, you go ahead. I can go second.
I mean, I don't know. I personally just thought it was literally crazy that like this scenario like happened in real life. Like it was actually kind of scary to see, how easily, I really liked when it was really talking about like the influences of like the environment and kind of like self-fulfilling prophecies and like seeing and making situations fit into what you have like a preconceived notion in your head already. And like, it's so crazy to me because, there's a lot of that I saw in, kind of like between like the article and the video, like talking about like how we're preconceived, our brain is wired to like make these snap judgments, and then we have to like be aware of these biases. And like just seeing that in like real action, like in this, basically where people were diagnosed as schizophrenic when they were, pseudo patients, I just thought that was crazy.
So like they were sitting there just taking notes, and that was like, oh, look at him, he's taking notes. That's a sign, it's a symptom of their schizophrenia.
Yeah.
Yeah, that's a good point. Yeah. So then everything that they did was seen from a framework of their diagnosis. Yeah. Victoria, what were you going to say?
Yeah, I agree with Charles. That was really crazy. And then when the pseudo patients were talking about when they got rid of their meds and they were also flushing them with all the medications from the other patients, it really made you wonder like how many patients were actually given the medicine and how poorly they were acting and everything. And then as well as they talked about one patient went up and actually tried to talk to one of the nurses and they just totally ignored them, act like they weren't a person. And another nurse like adjusted her bra in front of the room full of men because they didn't really see them as people. It was pretty frightening.
Yeah, well, let's talk about that, because that's one of my main points. What do you talk about? Like, what does that mean that a nurse wouldn't care and just adjust like an undergarment like that?
I think it would be like they don't see them as real men, I guess. Like they don't think that they're going to have any sexual attraction to them, or they're not real people, because I feel like the only time that someone would do that is if they think the person wouldn't understand what they're actually doing. So it made it feel like they didn't have any thoughts of them as humans. It was just another thing in the room, like who cares what they think kind of situation. So it was pretty upsetting to me.
Yeah, so the word would be, you're right. So the word would be dehumanization.
Mm-hmm.
Yeah. And so much of the article pointed at kind of the dehumanization process. And, 30 years ago when I started this, and I know my professors saw it a lot more than I did. They were older than I was, but, this was going on, way more than today, but it still goes on today. Like when as a minister, I go into a lot of homes for the elderly. I see this in a lot of facilities where they care for elderly people. I still see dehumanization, or like Alzheimer facilities and things like that. It still goes on quite a bit in all kinds of different facilities today, including some of the inpatient facilities. There's not as many inpatient facilities today, but there's still quite a few. But when this
It also
article was
kinda-
written, there were a lot more. Anne?
It also makes you kind of question the people who are working there. What kind of examination have they had on their psychological capacity to stand there and do that? Maybe there was something a little bit wrong with her too.
So there's a couple things. What do you think's going on with the people that work at these places if they act like that? What's going on with them?
I know I've personally seen a few seeking therapy and like TMS therapy and things like that who previously worked at some of the facilities that are closed in the Pittsburgh area. They said that they saw so much that it kind of rubbed off on them almost. So
yeah, so there's a few things that are going on. First of all, burnout, and when people have been in that field for years, they do get burned out. There's a lack of support for the personnel. They're overworked and tired. The other thing is a lot of times they don't have appropriate or enough training or the right degrees, or because there's a lack of funding, they don't pay enough. So, they hire people who basically don't have enough training and basically need the jobs. So there's all kinds of things that go into these situations. And now that there's not a lot of facilities, most of them have been closed down, like Mayview and a lot of other places have been closed down. And that's why there's a huge increase of homeless people that have psychological problems, because all the facilities were closed down. But now we see it in other areas where, like I was saying, homes for the elderly or Alzheimer's facilities or dementia facilities or things like that. We see the same things taking place that used to take place in facilities like this. So how about the medication thing? What'd you think about that whole medication thing in the article?
I found it really incredible how quickly they were to prescribe the medications, considering that to me, it would make more sense to kind of gauge the patient's baseline. And with prescription medications, there's a lot of side effects and symptoms that then could cause the patient to behave vastly different than they would have, that would not be due to whatever diagnoses they may or may not have. And then even just speaking to which the diagnostic process, even what we touched upon today, like the severity of the symptomology and the impact on their daily functioning, they were diagnosed with schizophrenia when they only had one symptom. And upon going to the actual inpatient facility, that symptom had ceased. So, I mean, I would argue that their daily functioning was absolutely fine. So it's just amazing to me that they would be prescribed medications so quickly and at such a severity level.
Yeah, that's true. I mean, the thing with schizophrenia is when you jump to that diagnosis, it never leaves you. It becomes schizophrenia in remission. So it doesn't go away. The medication thing, so many times, and so here's the word I like that you brought up, baseline. And the only way to get a baseline for a patient is to wean them off all medication, which usually means placing them in an inpatient program or a hospital, because you can't take them off all medication at home if there's any worry about them harming self or others, or that they may get sick being taken off so many medications. So there may be a physical reaction, but especially in children, like I've seen children who have been on medications for 6, 7 years, and if it wasn't working properly, they wouldn't take them off the medication. They'd add a different medication, a second, a third, a fourth medication. They changed the level of the medication, but they never took them off the medications. So usually when I saw a child, I'd rarely be the first one to get them, but I'd see a case history with, so many different medications. And if I saw them, if they had any physical side effect, like a tick, immediately, the first thing I would do is send them into a 14-day program where they would be weaned off all medication. And then I'd see them at a baseline for at least a month. And then we would re-diagnose after that period. But yeah, medication is also often the first line of treatment. A lot of times those side effects become permanent, which is unfortunate. That's what I like about counseling, is that let's try counseling first, and then if they need something else, we'll add medication and counseling. But a lot of times people try medication alone. Even if you want to try medication, it should be in combination with counseling, So yeah, good. So, and they're flushing all this medication and they're not taking it. There's been so many studies about how much medication is in our water supply. So not only from people flushing it, but from, it goes through our bloodstream and then out in our waste. So there is so much medication in our water supply, and then we reprocess our water supply, we clean out the waste, but the way we clean our water supply gets rid of impurities like waste, but it doesn't always get rid of the medication that's in our water supply. And they don't often test for medication. They test for fecal matter and urine and impurities, but they don't often test for all the medication. So, we might be taking some SSRIs and some birth control and, some other things that are pretty high in our water supply already, which is kind of interesting. All right, why was this study unethical? Why couldn't we do it today?
Something that kind of stood out for me with why it was unethical, because at first I didn't really think it was, but after reading one of the discussion posts, I one of the somebody in the class said the other patients really weren't aware of what was going on, and how this was kind of almost an invasion of their privacy and their rights. And I started to think about the mental impact it could have had on them if they were to find out they were kind of placed in this situation. Like they could have paranoia or mistrust for like those around them. So then I'm like, yeah, this was definitely unethical.
Okay, that's true, but that's the least unethical aspect of it. What's bigger unethical aspects?
I mean,
Okay.
honestly, whoops. Yeah. Honestly, I really thought that it wasn't really unethical. I actually thought that the insight gleaned from these experiments was so valuable, and nobody was really in any danger. I mean, the researchers had told, I think, a couple of administrators who they were. So I actually commented that I thought it was ethical because one of the other students that I responded to said that she compared it to the Stanford experiment, which is it's apples and oranges. I mean, that was unethical. Absolutely, that was a nightmare. Um, but I thought that I mean, how else are you going to get the insight of how these people are dehumanized? I thought it was a very telling when they were able to have nice conversations with the inmates. I guess you'd call them the inmates, the patients, because the patients saw them as peers, and they got to know them well enough to know that they probably weren't sick, whereas the staff saw them as almost like animals in a zoo or specimens or something. And it was I mean, how else are we going to know what goes on in these things and the different perspectives if we didn't have such an experiment? So that was my contention as far as I didn't find it unethical at all, but that was me.
So the positive thing you brought up, Frank, was that the other patients knew that they weren't insane. And that I found that very interesting. So the doctors thought that they were insane, but the other patients knew that they were sane.
Right. The doctors were myopic. You know, they only saw them as the diagnosis, and not even that. I think they depersonalized them so much that they just characterized them as subhuman, essentially, as specimens, animals, and just it's very sad that some people tend to do that. I don't know. It might be part of human nature that if you say, okay, these people are almost like the Stanford experiment in that if you say these people are bad criminals, they're less than worthy of being called civilized people. You tend to, or some people tend to believe that, and I think that's very saddening. And it actually leads to things like police brutality. And if you say, okay, well, it's us against them, these are your enemy. The public is your enemy, essentially. Don't trust them. They're suspect. You're going to have things like depersonalization to varying degrees. I mean, it's not so much, but prisoners of war are sometimes abused because even though they're not criminals, they're the enemy, so they must be bad. And it's just a darn shame, I think.
Yeah. I mean, it can be anything. It could be political views. It could be anything. Okay, both. I'm going to give you my response, but let's see if either Ashley comes up with it first. Both Ashleys had we're going to say something. So Ashley, mark them first and then the other Ashley.
Okay. So I was just thinking of how the patients were harmed by I don't know, there was like a few different things. Like one, they were prescribed medication, and half of them weren't even taking it. I don't know. I remember working in a psych ward for like a short period of time for like an internship or something, whatever. But like they checked your mouth. You know what I mean? Like they were just like, okay, like let me see your mouth, like let me make sure there's nothing in there. So they were like ensuring that they were taking their medicine. Then you know how Victoria talked about earlier, like the lady fixing her blouse, like her brassiere, you know, like who does that? Like that's unethical. It's kind of like you're, even though she didn't mean to, because she didn't like see them like as people, like that was wrong. And I'm trying to think, there was something else. There was also something that was talked about too, and I can't remember. Was one of the clients like hitting on one of the nurses? I think somewhere in that article, I can't remember, and can't remember if like the nurse like fed into it because they were all just like kind of just blew them off. There was that, and they were abused. Like there was a couple clients that were physically abused, and like they seen it, and they
Yeah.
were like kind of just like,
Restrained.
don't say anything. Yeah.
Yeah. Yeah. We're coming pretty close to this. Other Ashley?
The only thing I thought is it said that some of the participants were sent to good or better places, and some of them were sent to places where there was not enough staff. And so I would just be concerned for the patients that were already there, that the places that were already understaffed, and then you add these people who aren't real clients. Was that making life worse for the people that were already there in any way?
Oh, okay. All right. Good.
Oh wait, I have one other thing. I'm
Yeah,
sorry.
go ahead.
And their patient records were like, anybody could read it.
Anybody could read it. Yeah.
Yeah.
Yeah. Okay. So a lot of what everybody mentioned were unethical things that the hospital was doing. Okay. So that was unethical, but that's not what the experimenters were doing. They found out all those unethical things. But so here's what was unethical about the experiment. And it has to do with like what you said about now we check the mouths of the patients to see if they swallow the pills. So Frank, imagine somebody who's not schizophrenic and we give them all this medication and they're actually, you know, people going in for an experiment and they check their mouths and they make them take that medicine. That's the unethical part.
Well, that would be dangerous and unethical, but that wasn't the case. You know, that's why I contended. I posed the proposition that this is not an unethical experiment, because that wasn't the practice back then.
Yeah.
If it was, they would have had to modify the experiment somehow. It would have been a lot harder.
Yeah. So, yeah, technically they were supposed to take the medication. Unfortunately, well, fortunately for them, they didn't check. So everybody was, you know, spitting it in the toilet. But technically they were supposed to take that medication, but they got away with it. But if anybody would have made them take that medication, that would have been a big problem. So that's the unethical part, you know. But yeah, you
What
can't.
medication was it?
Situation. What's that?
What medication was it? Like lithium or something, Valium?
Oh, it could have been any medication for schizophrenia. Lithium would have been for bipolar, but it would have been the very earliest antipsychotic medication, which would have been almost experimental at that point. Yeah. And it probably would have been pretty potent. And probably a mixture of like chlorazepine and antipsychotics and you know, maybe a few shots. It's lucky they could have gotten some shots, but they were probably pretty docile, just taking notes at a table, so they didn't cause any problems.
The two participants actually did ingest the medication. I thought I saw that.
It could have been. I might have.
I think I saw that. And then the other obvious unethical part is there was deception involved, but I am curious because somebody wrote in their discussion post that the institutions couldn't withdraw from the experiment since they didn't know that they were in an experiment, at least initially. I would want to know, how would you have a system of checks and balances for these different institutions? Because I feel as though I always think back to when I was working in retail and the district manager was coming. I mean, we were
Oh,
extremely—
you're going to clean up the store. Everything's going to be folded and yeah.
Very performative aspect to when you know you're being watched. So
exactly.
to get like a genuine basis of how the patients are being treated without some level of deception.
Well, and they knew that, right? They knew that. So yeah. And then Melissa says some of our clients were non-compliant, so they started to get injections every couple months. Yeah. So, it's hard to get a real understanding of what's going on unless you kind of have a surprise inspection or something like that, So, but yeah, you can't do an experiment like this today. You would have to inform the hospital. You would have to get, approvals and everybody to sign off. It would be a big deal. And, the most you could do today would have kind of the administration be on board for an ethical inspection, of the facility without anybody knowing. But even that is very different than, being there for a long term. So the very first, this was not the first time this happened. The very first time this happened was way before. And I think her name was Nellie Bly, and I think she was from Pittsburgh. And I haven't watched the movie yet. It may be a horrible movie, but I'm hoping it's good. I want to watch it, but it's on, I think it's on Prime. I think Christina Ricci plays Nellie Bly, but it's about the first female reporter, and from Pittsburgh moves to New York City, and she does the same thing, but as a reporter. So she pretends she's, has emotional issues, gets placed in an insane asylum, which is what they were called then, and writes about how horrible the conditions were. And back then they were really bad. And, so I'm going to watch that movie, see if it's, appropriate or whether it's more sensational. But she was a real person, a real reporter, and one of the first female reporters. All right, so let's see if we can watch this response to this article. Let me share my screen. Where's share screen? Okay. And this is from your week 2, but it's only 5 minutes long. Boom, boom. Come on. All right, can you all see the video?
Yeah.
Yes.
Okay.
in 1887, an enterprising young journalist called Elizabeth Cochrane, who wrote under the name of Nellie Bly, pretended she'd gone mad, shouting, pulling out her hair and telling everyone else they were mad. And quite soon, doctors had her packed off to the Women's Lunatic Asylum, Blackwell Island, New York. Once inside the asylum, Nellie Bly behaved quite normally, but it made no difference. She was still treated as if she was completely mad. The saner I acted, she wrote in her book, 10 Days in a Madhouse, the crazier they thought I was. Nellie Bly had shown how easy it had been to fool the doctors, and also just how awful conditions were inside the asylum. 85 years later, a young clinical psychologist, David Rosenhan, would do much the same thing in relation to schizophrenia. According to most psychiatrists, schizophrenia is a disease of the brain, but diagnosis comes from behavior. Schizophrenics have delusions, hallucinations, irrational thoughts, and disordered behavior. But by the 1970s, some psychiatrists, like R.D. Laing, were starting to question the validity and reliability of these diagnoses. And David Rosenhan wondered if there was a way of testing these claims. How easy was it to tell the difference between sanity and insanity? Rosenhan must have been very persuasive, because somehow he managed to persuade 7 of his friends, 3 women and 4 men, to join him in an extraordinary experiment where they would pretend to have delusions and hallucinations and try to get themselves admitted to mental hospitals. It was an experiment from which psychiatry has never really recovered.
It's an exciting study, and when one reads it, it's difficult not to both be shocked and also to smile at the audacity of carrying out the study in the way that they did.
Rosenhan and his confederates traveled to 12 hospitals in 5 different states in the US. But they didn't act crazy like Nellie Bly had done. They just faked a single symptom.
When the pseudo patients turn up at the hospital, they would just say, I'm hearing a voice and it's saying to me, hollow, empty, thud. And the significance of this is that it doesn't represent any known symptom of a schizophrenic disorder.
So Rosenhan was giving the doctors a chance here to spot the fraud. But nonetheless, all the pseudo patients were admitted to hospitals. And once inside, they stopped faking. Apart from giving a false identity, everything they said was true, and they behaved quite normally. Hence the title of the study, Being Sane in Insane Places. When asked by the staff how they were feeling, they said they were fine. The symptom had disappeared, and could they please be released? So this was first of all a field experiment, the independent variable being the lack of symptoms in the pseudo patients once admitted, and the dependent variable, the responses of the staff to this. The pseudo patients were never detected by any member of the hospital staff. The only people who suspected they might not be for real were some of the other hospital patients. The pseudo patients remained in hospital for between 7 and 52 days, with an average stay of 19 days. Patients were released with a diagnosis of schizophrenia in remission. It seemed that behaving normally was not enough to get you out of a mental hospital. So how can this happen?
One of the most interesting findings, I think, was the fact that normal behaviour was reinterpreted as abnormal behaviour in the context of the hospital environment.
As soon as you are in a psychiatric hospital, then everything you do appears to confirm your psychiatric diagnosis.
For example, taking notes is a perfectly rational thing to do, but not if you've been diagnosed with schizophrenia. When one of the pseudo patients was seen taking notes, his case records read, "Patient indulges in bouts of writing behaviour." Clearly very worrying. And when patients were queuing for the cafeteria, a passing psychiatrist told his students that this behaviour was characteristic of the oral acquisitive nature of the condition. And it's not just patients' behaviour in hospital. Their past experiences were also reinterpreted through the lens of their diagnosis. As well as being a field experiment, Rosenhan's research was also a very rare participant observation study of life inside a mental hospital.
In his participant observation study, of course, he finds a very rich vein of information about what it's like to be the patient as to how you become a non-person. It's almost like you're not there, you're invisible. So the staff ignore you as you ask them questions. They treat you as a non-person, you become depersonalized.
Depersonalized and medicalized. Although they didn't take them, the 8 pseudo patients were given 2,100 tablets, an average of 15 a day per patient. Being sane in insane places was a very difficult study to do, and it took a lot of courage. The researchers couldn't wait to get out of the hospitals. But the study isn't about how hard it is to be sane in an insane place. The real lesson of Rosenhan's study is how hard it is to be psychologically troubled in an insane place.
So that's a little troubling too. The only thing we didn't talk about was that they found it very difficult to get out once they had gotten in. So that's a little troubling too. Okay, before we end, I want to talk a little bit about my lecture on the history of DSM. And I think it was pretty straightforward, but there were some interesting things like, you know, some of the cultural references basically, and some of the things they found from like the Stone Age, like triphoning, or you know, maybe like the things about mass hysteria. Or I just wanted to see if you had any comments or questions about my lecture on the history of the DSM before we closed. Anything interesting? Anything you needed clarification on?
I mean, I was laughing a little bit when I watched the video about like lycanthropy and stuff being in there. Like I mean, you see it in like
where they got the werewolves from.
Yeah.
Yeah.
I mean, I truly didn't know that that was like a part of like real diagnoses. Like I always just thought that was like mythical and made up for, you know, movies or whatever. But like I thought that, you know, and like the whole piece of like around like witchcraft and like, you know, all of that was really interesting. So it's crazy to think like how much we've kind of like evolved since that piece of like what we first thought of mental disorders to now. So, you know, and just overall like the cultural piece about like, you know, the different types of like rituals that are performed and thought as like normal, but in maybe like Western society are not seen as normal. So like really having to like challenge like our perception of, you know, like what is abnormal versus normal. Like, I don't know, I just very interested the whole way around.
So to us, you know, we're thinking like, okay, all that stuff with witchcraft and everything, that was so long, that was the Middle Ages, huh? You know, of course, you know, none of that was real, you know, and yet, you know, look at all the things people still struggle over, you know. So when we talk, you know, I reserved one evening, 1 week, just for human sexuality, because that class is not part of our curriculum. But like when I had my master's degree, we had to have an entire course on human sexuality and counseling. Some states still do require that. But the thing is, people are still challenged to think of some things as normal. And so I'm trying to find it's from This American Life, but he interviews a previous APA president, and he talks about how they changed the version of the DSM from including homosexuality as a diagnosis to not including it as a diagnosis. And the whole interview is just really fascinating how they went about doing that. And the quick answer is that the president of the American Psychiatric Association was gay. So that's how they did it. But you know, that's what it took. So, and that wasn't that long ago. So we might look at history and the Middle Ages, you know, but hey, you know, the DSM continues to evolve, and certain things weren't that long ago. So, and, you know, patients' rights and, you know, what we just viewed as an experiment in sane and insane places, that wasn't that long ago. And the rights of patients and the elderly and Alzheimer's and dementia and all of these things, you know, these things are still happening. Treating patients appropriately, you know, all this is still happening. So, you know, our profession is really all about caring for people. And we need to be good advocates for other human beings. And a lot of that starts with an appropriate diagnosis. So, okay. You do have, now that we're past that kind of intro week, each week you'll have many, not multiple, but many diagnoses within each week. I tried not to overdo it, but you'll basically have 2 weeks of class in 1 week, first of videos and lectures. So I think it's perfectly manageable, and you can work at your own pace, but try to get it done in a week, and you know, get your discussion posts done on time. And I think you can do it if you spread it out throughout the week. All right, you can always email me if you have any questions, but have a good week.